coming and being part of this with us. I am so pleased and honored to introduce you to Heidi Junk. Heidi Junk has been a member of our Johns Hopkins Sarcoidosis Patient Advisory Board since it began in 2020. She was thrilled to be involved in the creation of the first support group at Johns Hopkins, which I hope you look in your folders and learn more about if you haven't heard about it. Heidi was a patient advocate and patient navigator within the Foundation for Sarcoidosis Research and now serves on the board of directors for FSR. Heidi's challenging journey of 30 years with multisystem sarcoidosis has made her passionate about supporting others with the disease. She believes that by sharing our stories, we can help each other live well with sarcoidosis, and she wants everyone to know that in this fight against sarcoidosis, they are not alone. And it is with Heidi and the rest of our patient advisory board who have made this day happen. I thank you and I welcome you.
Hi, everybody. Good morning.
Good morning.
It is so great to be here with you all. Truly. It is so meaningful for me to be a part of this day. As Dr. Sharp said, it's something that we have been working on for a while. And I feel like, and I think they've touched on this, both of them have touched on this, it's a day like today that holds to me the two ingredients that give me hope, which is, being with others who know what it's like to live with sarcoidosis, and also to hear from the top experts in the field about the latest treatments and how to manage our disease, and also to help us understand what the heck is going on in our bodies, right? What is going on here? I often will say that this disease is like a game of whack-a-mole, because once you get one organ or one symptom or one side effect under control, another one pops right up, right? It's nonstop. And it's education summits like this one that give us the knowledge that we can use so that we can use our voices and that we can work with our doctors and partner with our doctors to get the best individualized care that we need for us. And I think it's something that puts us back in the driver's seat. It gives us control when oftentimes we have so little of it. So it's my hope, and it's the hope of all of us who created this event, that you leave here empowered by the knowledge that you gain, and that you also feel supported and seen by those around you. It's going to be a great day, and we have a lot jam-packed into it, so I just want to go over a couple of logistics. So let me share in your bags for those of us. So we've got you here in the audience, and then we've got you here online. So for those here in the audience, in your bag, you'll find this great folder. Has a lot of information. If you want to check it out, it has the agenda so you can follow along. It's got the bios of our awesome speakers, talks about the care team here at Hopkins, and also some information about participating in research. And you've also got 2 QR codes, one that will send you to the saysarcoidosis.org website, where you can learn more about our support group meetings and education about sarcoidosis. And then the other, I'll talk to you later about this, but we're gonna wanna know, how did we do? We're gonna want your feedback, so later in the day. So be thinking about that, things that we can do better. Also, just so you know, the goal is that after the speakers, each speaker, there'll be time for questions from the audience. So also in the bag was this awesome notebook. So you can use that to jot down any notes, any questions that might come up during the speakers. And we'll have Victoria and Abby walking through. You just raise your hand if you have a question after the speaker, and they'll be able to give you the microphone. You'll be able to ask a question. So, and if you have any questions here today, look for us in these t-shirts and with the purple flower necklaces, we should be able to answer any of your questions. And then finally, just make sure you do what you need to be comfortable today. So stand, stretch, go get water, take a break. This is all about you getting what you want and what you need out of this day. So just make sure you do what you need to do to be comfortable. And then, I know I've got a lot of stuff. For you online, there are 2 links today. So just make sure this first link is going to expire, I believe, at noon. And so then you need to go to that second link in order to get the second half of the day. Woo! Okay. You still with me? All right. So with that, we're going to begin this awesome day. So our first speaker is Dr. Catherine Bonham, and she is going to speak to us on Sarc 101, What We Know Right Now. So Dr. Kathy Bonham directs the Sarcoidosis and Interstitial Lung Disease Center of Excellence at the University of Virginia. She is an accomplished author on sarcoidosis, including the guideline for diagnosis of sarcoidosis. Her research focuses on the role of the immune system in sarcoidosis and how barriers to accessing care affect patient health outcomes. A native of Chicago, she loves baseball and pizza that is cut in squares. Love that. Dr. Bonham has always loved to read. She especially enjoys bedtime stories with her 4 children. Dr. Bonham, thank you.
Oh, thank you so much, Heidi. It's so fun to be here. I think I've been looking forward to this day. I've been in Baltimore a few days, having some scientific discussions, and today we're just going to have fun. So just going to get our slides here. Perfect. Okay. So I've been told that we should go a little faster so we stay on time. And don't worry, I know just the slides I'm going to cut. So Heidi already gave me a fantastic introduction. Thank you for that. I just want to tell you again, I feel like Simone Biles when they asked me to give this talk. I am here with joy, and we're going to have fun. We're going to talk a little bit about what is sarcoidosis, what we know about the causes, diagnosis, and treatment. And so I'm going to go through the history quickly. This is a disease that's been around for more than 100 years. It has been described in many ways. It has a funny name. It has to do with the Greek for skin, and that's because it was first described in the skin lesions. And so if you really don't like the sound of sarcoidosis, you could consider the first name that Dr. Hutchinson gave it, which was called Mortimer's malady, which is an absolutely awful name. You can see these 2. He saw Lady Mortimer, and she never came back. I'll just say to him after he described this. So sarcoidosis is fundamentally this disease where we have clusters of immune cells, white blood cells, and other cells that form this thing that's been called a granuloma. And the granulomas cause inflammation, and they interrupt, depending on where they are, the normal pathways and the workings of the body. You can think about this the way an oyster makes a pearl around a grain of sand, right? So oysters make pearls to protect themselves from an irritating particle. And in the same way, our body, our immune system, has this mechanism to kind of search out and surround things. And that's fundamentally kind of what a granuloma is. And so these are pictures of biopsies and kind of what a normal lung might look like. When we look at these under the slides and they're all stained, it kind of just looks like a big galaxy. But what we see with a trained eye is we see a lot of little inflammatory cells. I'm going to see if my pointer works. Does it? Does it? Maybe. Lots of little blue dots, right? So those are the inflammatory cells, and those are white blood cells and a mixture of other things. And in this picture, I've shown you an airway, okay, a little tiny breathing tube. And in this case, in this patient with sarcoidosis was full of mucus in their lung. And then there's also these little other ships that are kind of flying through all this inflammation. You see the little green circles? Those are what granulomas look like to us under the microscope. They're little clusters of cells. They're in there, and we can identify them with a practiced eye. Sarcoidosis granulomas have particular features. And someday when we all become pathologists, we'll understand all of those. But A good pathologist that specializes in this can actually separate out a sarcoidosis granuloma from other kinds of granulomas from other diseases. And so I mentioned this a little bit with my oyster analogy, but essentially you have to remember that granulomas, this is the cardinal kind of feature of sarcoidosis under the microscope, they really form, they're there because they're there to protect you, to wall off things that the body can't clear or fight off. In some situations, it's actually a normal reaction. So examples of things that the body can use a granuloma response against. Foreign bodies. If you get a splinter in your finger, a little piece of wood that's stuck there, your body can send an immune reaction against it, and often it's a granulomatous one. So this is a picture of that reaction, actually. This is a big little splinter sitting in a piece of tissue. And here are some those little ships, those little granulomas are right there, kind of trying to come in and surround the splinter. It's the same reaction that we get when we're approached with tuberculosis. So tuberculosis is another type of challenge that your immune system had to learn to respond to. Tuberculosis and sometimes other fungal diseases are really hard to get rid of with classic immune responses, the kind of immune responses we think about that are like antibodies, okay? If you take an antibody response and you try to get rid of tuberculosis using that, it's not too effective. So the body uses things like granulomas as another kind of response to kind of approach this. And we also know this happens when we're approached with things like metal dust, like beryllium, which is a perfect mimic of sarcoidosis. So, the million-dollar question is, what is sarcoidosis and what causes it, right? And when we think about these little mysterious packages of cells, what's inside there that's creating this reaction, right? So we've been looking for the cause of sarcoidosis for a very long time, and what we have found is that it is not easy to detect. There are theories. I cannot tell you right now what is the cause or the trigger of sarcoidosis. It's possible. It's different things for different people. The response, the sarcoidosis immune response is very similar to the one that we produce to things like tuberculosis and a related category of bacteria called mycobacteria. These are slow-growing bacteria. And those are things that are just in the water and the soil. So they're all around us all the time. And so, we think about are the granulomas from a mycobacteria. There's actually some data that the types of bacteria that give us acne can trigger in some patients a sarcoidosis. And there's even some really wild theories, things like phages. So phages are these little bitty viruses that sit on the top of bacteria. It's like Indiana Jones out there trying to figure out what's the Holy Grail, what is it, right? And there's actually a lot of budding research in this now again. I have to say, hearing some of the thoughts from the scientists that we were meeting with in the last 2 days for the national meeting, I think we're going to continue to see some progress in this area. I think another thing that's super important to think about is, we're very focused on trigger, but also after the things are triggered, is there actually something in the granuloma making process for patients that develop sarcoidosis, in that it's like a trigger, but then it just doesn't shut off, right? So patients who have sarcoidosis are really good at making granulomas. In fact, if you put blood cells from sarcoidosis patients into a dish with tuberculosis, so patients who have not seen tuberculosis before, so they shouldn't really react so robustly. Those cells go crazy, You're so good at making granulomas. When you see a really strong trigger to create a granulomatous response, something like tuberculosis, it's just wild in there. So certainly we know that, although we may not know the trigger, we know that patients who develop sarcoidosis are intensely good at making granulomas, and that's where the disease blossoms. Okay, so that was a long-winded thing. Doctor, what causes sarcoidosis? So if you ever watched House, it's kind of an older show now, right? Every other episode he considers sarcoidosis, right? But there's only one episode where it actually is sarcoidosis, okay? It's in the 5th season. So he had to get through a lot of episodes. So, if you have been diagnosed with sarcoidosis, by definition, we did not know what caused you to have this disease, okay? Other diseases, as I've mentioned, have granulomas on their biopsies, but you should have been tested for other diseases at the time of the diagnosis. That's part of the diagnostic process, especially when people receive biopsies that we're getting cultures. We're looking really hard for those other alternative diagnoses, and sometimes doing some additional testing beyond the biopsy to understand and make sure that we haven't missed something, right? So that brings me to diagnosis. So certainly, I talked a lot about granulomas. The granulomas on the biopsy support the diagnosis. They help rule out other diseases. And in our diagnostic guidelines, although in many cases we do recommend biopsy to strongly support the diagnosis, we give a little wiggle room to doctors and providers in the sense that sometimes you and your physician or your provider are talking about how severely you might be affected by what is believed to be sarcoidosis and whether or not treatment is recommended. And if treatment is not really recommended and you don't have a lot of symptoms, we say that you don't need to undergo a lot of additional diagnostic invasive procedures like biopsies over and over. It can be followed. There is that caveat in the diagnostic guidelines. That being said, in many cases, I do strongly recommend that biopsies are done whenever there is atypical features, when we're not sure, when we think, could there be one of the other very important alternative diagnoses out there? So we make sure we're not missing something. And another thing that I think also drives the recommendation to go for biopsy or not is the method in which that we biopsy. So 90% of patients that have sarcoidosis that affects their lungs, and often that comes along with lymph nodes inside the chest that are enlarged. And we now, 20 years ago, we did not have widespread ways to get at that tissue without really doing a big surgery. Technology has evolved. We have things now, there's special scopes, bronchoscopes, in which we can more non-invasively get to those lymph nodes. It's safer, and in general, that is now the more modern way that we're going after most sarcoidosis that affects the lungs. In some cases, depending on what's going on for you, you have a larger excisional biopsy, but the vast majority of patients can be reached with bronchoscopy, with ultrasound of their lymph nodes, and a needle biopsy, and that leaves no scars and is generally painless, and that's fantastic news. So we talked a lot about sort of alternative, we have to exclude other things. We have to know that there is no perfect test to detect or diagnose sarcoidosis 100% of the time. You still have to have, your provider and your doctor who thinks about the whole picture. And even after we diagnose someone with sarcoidosis, sometimes after diagnosis, important things come up. We can find that there is actually more evidence, for example, of fungal disease or other things. And so occasionally, after diagnosis, things can be revised. Another big question is, why does sarcoidosis affect me everywhere? And I think the answer to that is ultimately that your immune system is something that has to protect you everywhere. It's really a system that covers you not just in one region, but from the top of your head to the tip of your toes. And so, that means that when we get bad symptoms, fatigue, weight loss, sweats, feel achy all over, or all of this organ involvement, it's because your immune system truly is everywhere. And just like when you're using your immune system to fight off the flu and your immune system becomes activated, when you have an active immune response going on in sarcoidosis, you can feel that way, and it doesn't always feel good. How am I doing, guys? Am I working all right? Okay, very good. I like to go through a lot of the big questions I get from my patients. So another big one is, I mentioned 90% of people have some lung involvement, and if you read about lung involvement in sarcoidosis, you read about something called a scatting stage. Okay, so who's heard of that? Who's heard about scatting stages? Okay, so this is a staging system that an English physician came up with in 1961. He took about 120 patients and lined them up and said, I'm going to group these patients into stages, 1, 2, 3, 4. I think the worst one is 4, and that means that they have some scarring on their chest x-ray. I think the worst one is 1, and that means that they have some lymph nodes that are big on their chest x-ray, but the lungs look okay. And then in between are kind of 2 and 3. And that was some way, someone invented something, right? There was nothing before that. That was some way to try to gauge lung involvement or measure it or quantify it in some way, right? But it's a little misleading, right? Because we have stages now in other diseases like for lung cancer and so forth, and those are linked to prognosis much more tightly. That's actually not the case in the chest x-ray stages for sarcoidosis. So there isn't a logic movement. If you're a 1, you're not going to go to a 2 and then a 3 and then a 4, okay? So it is important to understand that 1 indicates a lymph node enlargement, and this can improve, but so does 2 and 3 sometimes on good treatment. And when we have a stage 4 chest x-ray, there is some evidence of some kind of fibrosis or scar inside the lungs. And in our lungs, we don't resolve scar. So that will be there. But it really is any fibrosis. So you could have a little bit, you can have a lot. And so the spectrum of that and what that means for your prognosis and how you feel can be very different. And it also does not necessarily mean that you're not going to improve with treatment, right? So, because you can have scar, but then also a lot of active inflammation. So it really is a much more nuanced understanding. And so really, I think chest scans, CT chests, are much more sensitive, and they're much more quantitative now. And eventually, I think this is going to become more of the norm and more of the way that we judge sarcoidosis involvement in the lungs. So please stay tuned for that. I'm going to skip lung function testing numbers because, you know, that can get a little dry. So let's talk about when to treat. There's really 2 major causes. So quality of life, and no one can tell me about your quality of life except you, and danger, right? So there's something to being your own disease expert and telling your treatment team, I feel bad, even though, you know, maybe my objective testing, like your scan, your lung function test, or your cardiac test looks okay, you can feel really bad. And that might be a reason to treat. The other reason to treat sometimes is when actually patients can feel pretty good, but there's might be some scary things on some of the testing that makes your team worry about having more, sometimes dangerous events, like cardiac things. So cardiac rhythm problems, for example, where you might actually feel pretty good, but if your cardiologist is saying, I don't like what this looks like, we might need to do like a pacemaker and ICD or treatment, that can sometimes be a reason why we use more aggressive treatment for sarcoidosis without a huge symptom burden or feel to the patient. So what do doctors worry about? So for me, I'm a pulmonologist, right? I worry about my patients that are developing signs of pulmonary fibrosis or pulmonary hypertension, that's scarring of the lungs or developing high pressures inside the lungs. Those are signs that the disease is can be more difficult to treat sometimes, certainly needs a more complex approach. And those are the patients that research has shown tend to have a little bit more worse prognosis, and we need to focus on them a lot. And then, of course, my colleagues in other specialties also worry about other things. Our goal is to intervene before these occur and really to treat aggressively when they do. I mentioned a little bit about pulmonary fibrosis. Since that's more of a subspecialty topic, I will skip it. The future, though, is that sarcoidosis patients are living longer. And that also means that sarcoidosis, I think, leading to more complex disease over time. And the data bears that out. This is a study, a large study of cardiac sarcoidosis. So these are hospital admissions between 2005 and 2014. And what it shows in the red is that there's more hospitalizations for cardiac sarcoidosis in the United States. But the blue line, which is the line that I care about deeply, is there is it's an equal decrease in the number of patients who die in the hospital of their cardiac sarcoidosis. That means we're getting better at treating it. So hospital care within the hospital is improving, and especially for cardiac disease. I think this is actually true of many cardiac diseases, not just cardiac sarcoidosis. But I think as we see this in cardiology, we're seeing this also in pulmonary, right, where people are living longer, but that also means that we have to think about what changes the lungs have accumulated over time and how to manage that. And I think, too, that there's therapeutics now, therapeutics also that are on the horizon. So as we get better at treating sarcoidosis, we also have to think about treating the complexity. So treatment, what are the options? So everybody's heard about prednisone, right? It's the devil's candy. It is important to know, if you don't know already, that medications other than steroids are safe and effective. And they're effective and can be safe when steroids fail, or if they're just not a choice for you. There are some pros to prednisone or steroid therapy for treating sarcoidosis. The pros, I think, are that, it's dirt cheap, it's always available, and it's kind of time-tested. We know what's going to happen with steroids. There's no surprises. And for many patients also, it's still the first-line treatment, and the reason is that they work pretty quickly, don't they? For most patients, they are fast-acting, and many of the therapies we have don't work that fast. And so there's a period where you are bridging someone who's in a period of acute inflammation, treating with steroids while you might be bringing on a second agent that eventually takes the place of that. I don't need to tell most of the audience about the undesirable side effects associated with prednisone. The medications that we presently use that are oral by mouth to replace steroids, this is a list of some of the major ones. Methotrexate is first line in the steroid-sparing armamentarium for a lot of patients. How we choose what to do really depends on your other medical conditions. Do you have some chronic kidney disease? Do you have any liver function abnormalities, for example? Do you have a history of skin cancer? Are you going to be able to tolerate some of these medications? Especially methotrexate sometimes causes a lot of stomach upset and nausea. So we have to be nuanced in our choices for these, and we have to think about, too, whether or not some of these medications are useful for the organ that happens to be involved for you. So, for example, I use hydroxychloroquine, which is also called Plaquenil, and it can be very useful for patients that have joint involvement, sometimes patients that have a lot of high calcium levels. It's not terribly good for treating pulmonary sarcoidosis. It can be a great adjunct therapy. And then the other thing is, for some patients, dual therapy is now a controversial but I think exciting topic, too. And whether or not, especially for patients who have some serious organ involvement or a large burden of symptoms, whether we're starting some dual therapy up front. So, and especially, I'm a big advocate for a lot of patients who have severe disease of starting your steroid and your steroid-sparing medication at the same time. That allows you to get off steroids faster, and so I think that puts you one step ahead. Beyond these medications that we take by mouth, which are usually our next reach after steroids, or sometimes together with steroids, we have injectable and IV infusion medications. Infliximab and adalimumab, also called Humira and Remicade, there are many biosimilar names as well now, are really the mainstays now often for advanced or complex sarcoidosis. They come with a lot of caveats, of course. They require some monitoring. They require an investment of time and often money as well to receive these medications. And so I think a big fight in the field is finding either space to be able to do trials of these so that we can get approval for sarcoidosis patients to use this important category of medications. Developing more kind of biosimilar medications are ones that are molecularly very similar to these medications, and they act in the same way, but they can be FDA approved as a separate drug. And doing that in sarcoidosis populations, I think, is quite important. And then sometimes as a last-ditch effort, we do something called rituximab, which is a B-cell modulator. And that is done rarely, but can sometimes be useful. I just want to say it's an exciting time for treatments and trials. In the last 2 or 3 years, really, we've had investment from industry with novel therapeutics and clinical trials, and a few of them now are just coming to the phase of completing their enrollment and analyzing the preliminary data. And I think we're going to hear in the next year or two the results of those trials, and I think it's going to be very exciting. And if you are actually participating in any of these clinical trials right now, thank you. Also looking to the future, patient registries are incredibly important. They help us understand the history of the disease. They help us do some really important science. This is just one example in which patients who were enrolled in a registry across Europe were able to contribute some blood samples, and the authors here, who published in a very important journal, were able to actually kind of describe the gene and the gene interactions with what we see in the patients. So describing clusters of organ involvement and how that is reflected in their genetic profiles. Incredibly interesting, and some research that this group is continuing to do. And it all really comes from patient involvement, which is fantastic. While I'm talking about treatment, I just want to also highlight how important it is to think about non-drug therapies, including exercise. Exercise is so important. This is one study that talked about that. And you can see when sarcoidosis patients are enrolled in a formal program, this was a 3-week program, everything gets better when they're able to do more. So quality of life, shortness of breath, anxiety, depression, and they walk farther. I mean, those are great quantifiable and functional outcomes. And then finally, I have optimism about the technology in the space too. Even alone, I mentioned bronchoscopy, so our new types of bronchoscopy, which allows us to diagnose sarcoidosis more safely, but also allows us to reach the lymph nodes in the chest in a more safe way so that we can do very interesting research. So we're able to look at things like the cells in the lymph nodes in the chest and understand how the granulomas form there and what the cells are doing in a way that we could not do before. And so we're just in a time of incredible scientific innovation. And I think that's so important to have hope about, really. So thank you. Thank you. So sarcoidosis, remember, this is a complex disease, and one size does not fit all. You're going to hear from some of the speakers today about the new things that are happening in the field, but also that we are not doing protocolized care. We are looking at everyone as an individual, trying to understand the parts of the body that are involved, what treatments work. And I think as we look at new therapies in the pipeline, that is going to be exciting to understand. Do we have therapies that are helpful to some personalized aspects of sarcoidosis? So the future is bright. And thank you for spending a few minutes with me.
Thank you so much.